but not least, Francesco Oddone will cover a challenging and promising topic, neuroprotective strategies in glaucoma.
So I would like, first of all, to thank Professor Konstas for involving me in this symposium and Zwitter for the organization. And so I've been asked to talk about current neuroprotective strategies in glaucoma. I would like also to start pointing out a definition of glaucoma where we can find the characters of glaucoma. Mainly, glaucoma can be considered as a neurodegenerative disease, and in this context it belongs to the same family of Alzheimer's disease, amyotrophic lateral sclerosis and Parkinson's disease. So all these diseases have in common some features. First of all, they are all chronic with progressing evolution. Second, they have similar mechanism of cell death, which is mainly apoptosis. They are also, they have in common the fact that a selective loss of specific neural population occur in each of these diseases. And then another common feature is the transsynaptic degeneration, which is something that characterizes all these neurodegenerative diseases. Talking about specific neuronal loss, in Alzheimer's disease we face the loss of hippocampal neurons. In Parkinson's disease, the dopaminergic neurons. In the ALS are motor neurons that are dying mainly. And in glaucoma, we know that this population which is specifically targeted by disease is the retinal ganglion cell. And talking about transsynaptic degeneration is a mechanism of death that is transmitted from neuron to neuron through the synapses. And it is another common feature of all these diseases, and it is proved to be present also in glaucoma. And the first evidences about the fact that glaucoma causes a transsynaptic degeneration of neurons was probably observed by the group of Ussel and Gupta. And these images, probably you have seen already before, became very famous because for the first time it was observed that along with the glaucomatous changes at the level of the optic nerve head, it was possible to observe also a shrinkage of the tissue within the lateral geniculus nucleus and in the visual cortex, as you see below. So it was the first evidence that there was a kind of transmission of the death signal from the eye to the brain. And then, more recently, it was possible to observe similar changes, actually the same changes, with more modern technological advancements, using the high-intensity magnetic resonance. And specifically, it was observed a reduction in the thickness of the visual cortex that was correlated with the reduction in thickness of the retinal nerve fiber layer. And more recently, a group of Italian researchers, or coordinated by Professor Frezzotti in Siena, explored also other areas of the brain in glaucoma and control subjects, and they found changes also in areas of the brain different from the main visual cortex, mainly associative areas, so demonstrating that glaucoma involves not only the visual pathways but also other cortical areas. So these evidences together suggest that both the retinal ganglion cell and the brain should be targeted when we consider both diagnostic procedures and therapeutic strategies for glaucoma. So we all know also that from the large clinical trials that the main pillar of our treatment strategies is the reduction of intraocular pressure. So there is something ongoing on half of the screen, but you can see at least the UK GTS, which is the most modern of these trials. Mainly, in the meanwhile, they try to sort out the technical problem. I can tell that in all of the trials we know about the effect of intraocular pressure in glaucoma, and specifically I'm talking about early manifest glaucoma treatment study, so the AMGT, the CNTGS, so the collaborative normal tension glaucoma study, and more recently the UK GTS, that intraocular pressure reduction allows to reduce the proportion of patients that show progression. But those trials are telling us also something different. If we look at these numbers, actually you can look only at one number here, but they show the proportion of patients that still progress despite the intraocular pressure is reduced. And of course, this proportion of patients that are progressing despite the intraocular pressure reduction can be related to several issues. One issue, for example, is the compliance of the patients with the therapy. Maybe the patients were not taking therapy. Another issue could be that the reduction of pressure was not strong enough to stop the disease progression in all patients. But another possible mechanism underlying this progressing patient could be that there are other factors different from IOP that are causing progression in those population, those patients. And it's becoming a bit difficult to go on without the slides, not for me, but mainly for you, so I can keep going. But anyway, we see something that can be helpful, even in the half slide, which is this round circle, red circle around one word. And what is missing from the slide is that just a list of possible alternative mechanism of neuron death that could be contributed to the death of the cells in glaucoma. And we have seen those mechanisms also in the talks of the previous speakers. But what we see on the right-hand side of the slide is the word neuroprotection. So all these different mechanisms of damage could be targeted by one single strategy, which is neuroprotection. And neuroprotection has been defined in many ways. There are the European Glaucoma Society guidelines that defined neuroprotection, and many other investigators and guidelines define the concept of neuroprotection. Mainly, we can define neuroprotection as the therapeutic paradigm designed to slow or prevent the death of neurons to maintain physiological function. In this sense, although the intraocular pressure lowering strategies are neuroprotective because we are protecting neurons through the reduction of the intraocular pressure. But more specifically, when we speak about neuroprotection, we speak about direct neuroprotective activity, so something that acts on the survival of the neurons independently from the reduction of the intraocular pressure. And there is another concept that you can half read, which is neuroenhancement. Neuroenhancement is probably a less known concept. Neuroenhancement belongs to the fact that you can in some way increase the function of the surviving neurons for a short period of time with some drugs, and the effect usually is dose dependent. So if you use a kind of a neuroenhancing agent, you can increase the function of the surviving neurons. When you stop the drug, the function will get back at the baseline values. So this is the concept of neuroenhancement. Now it's very difficult because this is very time. Oh, yes. Okay. But anyway, I'll be very quick on this. Maybe it's a kind of plug or connector. You can try to plug it. It's the screen. So maybe a little kick to the screen. Sometimes it works. We try. Technician behind is working. Okay, fantastic. It's a bit more, but we will manage to do it anyway. I mean, this slide, I mean, we don't need to go through this complex mechanism, so it's just to show that about neuroprotection in glaucoma, we started to speak probably around the year 2000. I mean, there were also many studies before, but it became very popular when the first agent was tried in a clinical trial to prove its effectiveness in protecting neurons in glaucoma. That was about memantine. You all know about memantine. This was the object of probably the largest clinical trial conducted in glaucoma in neuroprotection. And you know also the results of the trial because the trial failed to prove any neuroprotective activity for memantine, at least in glaucoma. There were some issues regarding the study design and the way the visual fields were analyzed. Nevertheless, the results were never published, even if negative should have been published to know exactly where the issues. But after that, I think that the other study that was published more recently about something that could have neuroprotective properties was the low GTS. You might have known about it. It's the low tension glaucoma treatment study. Mainly it is a randomized, multicenter, double-mask clinical trial involving normal tension glaucoma subjects, 190 subjects actually, that were randomized to be treated with timolol or brimonidine. They have a similar effect of intraocular pressure, so they reduce the pressure to a similar extent. And so the investigators look at the survival of visual fields, so the proportion of patients showing progression in the visual field in the two arms of the study. Despite the intraocular pressure was very similar, as you see in the left-hand side, between the two arms, actually in the timolol group was even a bit lower than the brimonidine group. The survival graph on the right-hand side of the screen is showing that a higher proportion of patients treated with brimonidine were not progressing. And this was significant. And so this was the first time that brimonidine in a proper clinical trial was showed to have some kind of action related to the chances of protecting patients to progression. But some issues were raised about the validity of these results because, as you don't see in the bottom of the slide, a very high proportion of patients in the brimonidine group discontinued the study because of allergy. And so we could never know if those patients were in the future would have progressed or not. And so the results were significantly impaired by this problem. And so now we come to citicoline. Citicoline is another molecule that was studied a lot since several decades, not only in glaucoma, but also in other neurodegenerative diseases, and as a potential neuroprotectant. And this is just a partial list of the huge amount of papers published in citicoline, which overall was tested on more than 11,000 subjects in clinical studies, not in glaucoma, but in all neurodegenerative diseases, mainly on Alzheimer's, Parkinson, and other neurodegenerative diseases, and also in glaucoma. And there is an increasing number of published clinical studies in glaucoma. There is a lot of literature about basic studies in glaucoma, but now also the number of studies involving human subjects is increasing. Most of them are on electrophysiology, but now I will show you some results also about studies that deal with visual fields, which is something that is probably more related with the quality of life of our patients. And most of this literature was summarized by a review that was performed by our group and published a couple of years ago on the International Journal of Molecular Science. So what is citicoline? This is much better, but if the technician can just try to adjust something more, will be even better. And anyway, what is citicoline? Because we are used to speak about this molecule, but very often we don't know exactly what is it and what are the mechanisms, the supposed mechanism of action underlying the neuroprotective potential. So citicoline is a precursor, is an intermediate in the synthesis of the membrane phospholipid called phosphatidylcholine. Phosphatidylcholine is the phospholipid that build up 90% of the cell membranes, including neurons. And this particularly fact deals with the fact that there is a structural action of citicoline in terms of rebuilding of the cell membranes and neuron membranes. And then there is a functional action because in the metabolism of citicoline are produced some neurotransmitters, in specifically dopamine and acetylcholine. And so the increase of the levels of these neurotransmitters is related to neuro-enhancing properties of this molecule. So we could suppose a structural action that probably is more related with the long-term neuroprotective potential of this molecule, and a functional action that is more related to the neuroenhancement properties in the short term of this molecule. And you don't see, but the acetylcholine is available and was studied a lot as an intramuscular intravenous injection, which is not very practical for our patients. And since probably 15 to 20 years is also available in oral solution. And just more recently was developed also an ophthalmic solution in eye drops. And so there is a difference in the route of administration, but what is in common for the systemic administration is that it could be read anyway. So we have acetylcholine, which is taken by mouth. It arrives to the gut mucosa. Here it is hydrolyzed in two molecules, which are choline and uridine. This goes into the blood. This can pass the blood-brain barrier, and within the brain, they are synthesized again as acetylcholine. So this pathway is concentration dependent. So the reformation of acetylcholine in the brain is concentration dependent. So it's very important that the acetylcholine is absorbed very, very quickly at the gut level. And so this is allowed just by the oral solution, because if you take acetylcholine, for example, in granules, they have to be disaggregated and dissolved and then absorbed. So the absorption is very slow. While the solution is already in solution, it goes immediately in contact with the gut mucosa, it is absorbed immediately, and the bioavailability has been observed, has been proved to be 98% of the intravenous injection. See, it's like you do an intravenous injection of acetylcholine if you take it orally in oral solution. So there are a lot of, as I told you before, there are a lot of studies about electrophysiology in the use of acetylcholine, and this is probably one of the first that showed the effect on the VEP of acetylcholine, and on top of this down there, okay, it's not working the pointer, but down there you see the VEP completely disorganized the structure of advanced glaucomatous patients, and in the same patients you see the VEP which is significantly changed after a period of acetylcholine intake in oral. And so this is just one example. There are many, but as I told you, I do want to speak about electrophysiology in this talk. I would like to speak about something that is more related with the clinical practice, which is visual fields. And so I would like to share with you the first evidence about the use of acetylcholine and the effect of acetylcholine on the rate of progression of visual fields. So this is a paper published in 2013 by a group of Italian researchers. It was a 2 years multi-center prospective single-arm clinical study, and the primary outcome was to assess the possible effect of acetylcholine on the rate of progression in glaucoma. So the patients that were included were patients that showed progression of, for the past 3 years, for the previous 3 years, of at least 1 decibel a year. And they had to have at least 2 visual fields per year reliable in the past 3 years, and the pressure should have been always below 18 millimeters of mercury. So pressure were controlled and proved progression of the visual field. So those patients at baseline, after this background, were treated with acetylcholine with this kind of scheme. So for 4 months and pauses of 2 months, and then 4 months and 2 months for 4 times. And so the inclusion criteria were very hard to meet, to reach, and so they started to screen more than 1,500 patients, and they managed to enroll only 41 patients in the trial. Because, I mean, it's not very easy to find people with pressure below 80 millimeters of mercury, with reliable visual fields, and showing at least 1 decibel a year of progression of visual fields. And actually, the progression of visual field, the rate of progression before starting caticoline was, I don't know, yes, you can read here on the right-hand side, was minus 1.1 decibel a year. This was before starting the study. And now I show you the result. And this is very difficult to put together all these lines, these scattered lines. Anyway, it could be, no, this cannot be go. Anyway, you can see on the right-hand side, the sloping line is showing the rate of progression before starting treatment. So this corresponds to minus 1.1 decibel a year, as I just told you before. And the starting point, the mean deviation was minus 7 decibels. So exactly at the middle of the graph, you have the start of treatment, and then you see after the treatment, during the follow-up, the significant change in the rate of progression, in the slope of the line, which from very diagonal becomes almost horizontal. And the final rate of progression in the second part of the study was minus 0.15. So from minus 1.1 to minus 0.15. That corresponds to minus 86% in the rate of progression per year. So it was a strong effect on the rate of progression. And there were some limitations of the study. One limitation was that there was no control arm, it was a single arm study, and then the mean IOP during the study, which had to be below 18, but changed from 15.5 to 14.4, so there was 1 millimeter change in intraocular pressure that could have contributed to this change in the rate of progression, and the fact that the population was relatively small, as I told you, 41 patients. So this could be considered as a pilot study that the first time showed an effect of this molecule on the visual field rate of progression. So there is it looks like Picasso a bit. Well, don't you think? It's a kind of modern art. Anyway, there is an ongoing clinical trial, very large, involving several centers in Italy, not in Italy, in Europe actually, because it involves Luca Rossetti in Italy, Fotis Topouzis here in Thessaloniki, Professor Manni at our institution in Rome, Ingeborg Stalmans in Leuven in Belgium, and Francisco Goni in Barcelona. So it's quite a large study, and that just started, and there are 220 patients enrolled in this large study, and the design is, as you can see here, is a crossover study, and the primary endpoint is the this quality of life as measured by VFQ-25. So it's the first time that a neuroprotectant agent is studied on quality of life. And secondary endpoints, of course, include visual fields and several other things. So, as I told you, it's just started. Probably we have to wait at least a couple of years to have the final results. But I think that will contribute a lot about our knowledge about this molecule. And now, as I told you, from the oral solution, we have also the ophthalmic solution. Actually, in Greece, you had first the ophthalmic solution and then just recently the oral solution. And the first problem of the ophthalmic solution was to try to find a strategy to allow the molecule of citicoline, which is very large, to penetrate into the eye, and so to reach the vitreous and the retina to be active. And so this because the molecule is not only large but also lipophilic, and so it cannot cross the cornea, the conjunctiva, and the sclera as much as is needed to reach the therapeutical effect. And so mainly this is due to the fact that the tight junction and the gap junction between the cells are too narrow, and so the molecules cannot go in. So the strategy that was found to increase the penetrability of the citicoline molecule was to use BAK. A low concentration of BAK acts on the tight junction between the cells by increasing the distance between the cells, and so allowing the molecule of citicoline passing into the tissue, and so penetrating into the eye. Together with with also another molecule, which is hyaluronic acid, that increase the time of resting of the molecule on the ocular surface. The two strategies together allowed the molecule to enter the eye. And if it goes, yes, as you see here, so high molecular weight hyaluronic acid and BAK. And this allowed to have an international patent. And but after that, we wanted to study if actually the molecule could be found inside the eye, because this was just theory. So it has to be proven in practice that the molecule can enter actually in the vitreous and reach the retina. And so we performed this preliminary study with the first phase, which was experimental, and second phase, which was clinical. Mainly in the experimental phase, the acetylcholine eye drops were used on rabbits' eyes, and then vitrectomy was performed, and in the search of the molecule inside the vitreous of these animals. And as you can see from this peak, the acetylcholine was present in high concentration inside the vitreous of these little animals. Actually, we wanted also to replicate this information, this data in human eyes, and we are doing it because there is another clinical trial ongoing at my place where patients undergoing vitrectomy for macular pucker are treated for 2 weeks with acetylcholine eye drops, and then dry vitrectomy is done, dry tap is done before starting the proper vitrectomy, and in the search of acetylcholine. So we have collected so far 6 samples, we have to arrive at 20, and I hopefully next time I will be able to show you the results. And okay, in the clinical phase of the same study, mainly 34 patients were randomized to be treated with acetylcholine or hypotensive eye drops. And so mainly, these were the results. So the sample population was small, but was the first time that the eye drops were tested on human eyes. And so mainly what was observed was a decrease in PRG latency, an increase in PRG amplitude, and with similar intraocular pressure in the 2 groups. So this was the first evidence about a possible effect on the visual function of acetylcholine when given in eye drops. And MD and PSD on the visual field did not show any statistically significant change, even if you can see there was a trend of improving MD and PSD during the study. But again, there were several limitations of this approach. It was just a pilot study, small sample size, short follow-up, and no control arm. And so there is another study published in 2015, which was much more structured. Again, a small population, we were 55 glaucomatous patients, but it was a randomized study, prospective and single mask. So the level of evidence is increasing. And so this study involved glaucoma patients with pressure below 18 millimeters of mercury, and that used the eye drops of acetylcholine for 3 times a day for 4 months, followed by 2 months of washout. And so the results mainly are reported here. Again, there was observed an increase in PERG amplitude, an increase also in VEP amplitude, and a decrease in VEP latency. So the similar effects that were observed in the pilot study. Again, limitations, short follow-up, not powered, not randomized, not masked, and single center. So we are increasing the level of evidence, but we are not reaching what we want to have. So evidence from randomized controlled trials. And actually, I will not show the results about the randomized control trial because it is ongoing, because since the interest is becoming higher and higher about this molecule, also the investments and the efforts from the research point of view are increasing. And so there is a multi-center randomized control trial ongoing in Italy that you see involved 90 patients that were randomized in the 2 arms, one using just placebo plus hypotensive therapy, and the other one acetylcholine eye drops plus hypotensive therapy. And we know that, and I'm going to finish, that also just a couple of shots about the fact that the interest on this molecule is so high that also other fields of ophthalmology are studying the same molecule, and specifically in diabetic retinopathy. We know that there is a strong neuronal and neurodegenerative component in diabetic retinopathy, and as we can see in this model, in this animal model, the addition of acetylcholine can reduce the synaptic damage and the apoptosis caused by high glucose. And there is a small randomized controlled trial, which is just a pilot trial, which is ongoing since 1 year. It has to last 2 years. And it is very similar to what we have seen for the glaucoma trial, but is involving diabetic retinopathy patients, so patients with diabetes, type 1 diabetes. And we will see the results, I think, in 1 year. So to conclude, there is the need for effective treatment strategies such as neuroprotection and neuroenhancement in glaucoma, especially for those patients that still progress despite intraocular pressure in the normal range. So preclinical and preliminary clinical data show promising results about the efficacy of acetylcholine on visual function in glaucoma. We need appropriately designed randomized controlled trials that are ongoing and that will help to increase the level of evidence about the effects of acetylcholine oral solution and eye drops on both disease progression and, most importantly, on quality of life of our patients. And with this, I finish my talk. Thank you very much for your attention.